Want to welcome you all here today. We're going to be starting in just 1 minute as people filter in. And I want to, again, welcome you to today's second installment of Bioethics with Bigger Impact. I'm Elizabeth Lanfear. I'm a co-editor of a symposium in perspectives in biology and medicine, along with Larry Churchill, on the translational work of bioethics. And this presentation is in partnership with Perspectives in Biology and Medicine and the Hastings Center. And I want to let you know that our presenters will be visible today, but the audience and participants will not be. You will have an opportunity to direct questions in the Q&A throughout the talk. So please, as your questions arise, don't hesitate to raise them. And we will have a recording of this session later today on the Hastings Center website, as well as later on the Center for Public Engagement with Science's YouTube page. So the next session, just a preview, will be our third session in the Bioethics with Bigger Impact series later this spring, and it will be on environment and climate ethics and bioethics role. So also, just want to mention really briefly one other thing as we get going, that the entire issue of the translational work on bioethics in perspectives in biology and medicine is currently freely accessible on the Project Muse website. So I really encourage you to check out the articles by today's authors, as well as all of the work in that symposium after this session. So it's my great pleasure to introduce our moderator for today, Dr. Jennifer James, whose expertise as a qualitative researcher and Black feminist scholar researching at the intersection of race, gender, and health is really the perfect person to help us synthesize today's topics about transformative justice and social determinants of health. Dr. James is an assistant professor in the Institute of Health and Aging, the Department of Social and Behavioral Sciences, and the Bioethics program at the University of California, San Francisco. She uses community-engaged research and an intersectional framework to explore ethical issues related to experiences of illness, patient-provider relationships, and resistance and resilience in biomedicine. Dr. James is a true leader in bioethics as a current Greenwall Scholar and an elected member of the Board of Directors of the American Society for Bioethics and Humanities. So thank you so much for joining us today, and I'm going to turn the floor over to you.
Thank you so much for that lovely introduction. And I'm so thrilled to see so many folks here today for this great conversation. If you haven't had a chance to read this special issue and these papers, I really highly recommend, and I'm so excited for our conversation. So our plan for today, so we are going to hear from the authors of two papers. I'll introduce them both. They'll sort of each give a little bit of an overview. Then I get to offer a few brief comments and sort of raise some of my own questions, which is always the great thing about being invited into these spaces. And then we're going to leave lots of time for audience Q&A and really have a conversation among all the speakers. So please make sure as we go, you're putting questions in the Q&A that we can pose to our speakers and make sure we have a great conversation. So I will start by introducing our first two speakers, Drs. Gina Campelia and Holly Vo. Dr. Campelia is an assistant professor in the Department of Bioethics and Humanities at the University of Washington School of Medicine and a clinical ethics consultant for UW Medicine Ethics Consultation Service. In scholarship, teaching, and practice, Dr. Campelia translates ethical theories to clinical practice, mediating or facilitating resolution of conflicts and values. Her publications concentrate on critical theory and counteracting race-based and gender-based oppression in healthcare, as well as expanding the applications of relationality, empathy, epistemology, and feminist ethics to clinical ethics. Dr. Vo is an assistant professor in the Department of Pediatrics at the University of Washington School of Medicine and Seattle's Children's Hospital in the divisions of pulmonary and sleep medicine and bioethics and palliative care. She is also a clinical ethics consultant for Seattle Children's Hospital. Her scholarship focuses on the practice of shared decision-making, advancing health equity, and improving comprehensive care for children with medical complexity. So please join me in welcoming Drs. Campelia and Vo. Turn it over to you.
Hi, everybody. Thanks so much for having us. We are really thrilled to be here, honored to be a part of this conversation. And we just wanted to start off by saying that our work on this project in particular is indebted to our co-authors as well, Alex and Tracy, as well as the insights of another cherished colleague, Maya Scott, and many of the other ethics colleagues we have, healthcare professionals we've worked with, as well as patients and families along the way. I wanted to start just with some of the motivation for this project. As a feminist philosopher, a white ally working in clinical spaces, really been driven by deconstructing and reimagining relationships of power and oppression, especially in the clinical setting. And in many ways, movements to dismantle oppression since the mid to late 20th century have not changed. Axes of oppression have not gone away. They've shifted maybe or become more hidden in certain ways. And so just as we start the essay, we wanted to start today with this quote from Audre Lorde from an event in 1984, where she states, "Racism and homophobia are real conditions of all our lives in this place and time. I urge each one of us here to reach down into that deep place of knowledge inside herself and touch that terror and loathing of any difference that lives there. See whose face it wears." Audre Lorde made this statement about 3 years before Bernard Lowe's essay, Behind Closed Doors, Promises and Pitfalls of Ethics Committees, where he identifies ethics committees or concerns with ethics committees relating to representation, groupthink, and ultimately judgments about fairness, but without explicitly discussing axes of oppression. But of course, the connection between the two can be readily made. And over the last several decades, critiques of mainstream bioethics from critical theory, such as feminist theory, Black bioethics, disability theorists, queer theorists, continue to drive home significant issues of marginalization and representation in the field of bioethics generally. What we're here to talk about today is how we experience these concerns acutely in our work in healthcare as healthcare ethics consultants, feeling sometimes constrained by ethics operating behind closed doors and reliance on standard ethical approaches that don't always resonate with the patients and families who we're connecting with in our consultation. And so I'll turn it over now to my colleague, Dr. Vo, for a look at a particular case, just to see a little bit more in depth what we're seeing in the clinical setting.
Thank you. As Gina mentioned, we've both encountered clinical situations where it's unclear how we should approach the ethical dilemma due to tensions between various ethical frameworks and values, and especially in contexts where one ethical framework may be privileged unfairly over another. So here we present a case that illustrates this tension. Vivian is a 50-year-old who was found down by a neighbor and now admitted for severe anoxic brain injury following cardiac arrest. Consensus from the medical team is that she's medically stable, but unlikely to regain consciousness or breathe independently, and is at risk for complications associated with prolonged ventilation. Vivian is very close to her family, and a family care conference was held to discuss next steps. Her husband and daughter prefer a do not attempt resuscitation code status, as Vivian has previously explicitly stated not wanting to stay on a ventilator without hope of regaining consciousness. This is in contrast to her mother, who actually pleads for full code and additional and all interventions. A private family meeting was then held, with the result being that they agreed to not attempt resuscitation, but that she remain on the ventilator for another 2 months to assess next steps. Her husband admits that though Vivian likely wouldn't want to remain on ventilation, he was not sure how she'd balance her own wants with the obligation to her own family preferences and relationships, given its importance in her family's value systems. So since it's unclear how Vivian would have proceeded, there may be a few different approaches how an ethics consultant would weigh the different treatment options. The ethics consultant and healthcare team may choose to, 1, prioritize respect for autonomy, and thoughtfully but firmly transition withdrawing life-sustaining therapy in line with her reported express preference, possibly over the family's objections. They may choose to act on the primacy of respect for autonomy, but incorporating the possibility that she would have valued her family's preferences, possibly continuing LST for a time. Or, as was saying on the third option here, recognizing differences in the value-based frameworks guiding healthcare professionals and family, they may choose to center the family's relational approach alongside individual autonomy-centered approaches and possibly continue LST for a time. So one caveat is that we know that this is a lot more complicated than it appears here in this slide, and there's a lot more gray between these different approaches. However, when each of these paths is pushed to its own logical conclusion, this is what we may end up getting. And though the second and third paths lead to the same medical action, the third allows us to actually center the family's value system instead of centering our own and trying to mold theirs to fit into ours. When we consult in cases like this, sometimes we feel constrained in our ability to equally consider the second and third paths alongside respect for autonomy. As ethics consultants, we've often relied on Beecham and Childress's principles of biomedical ethics. And although Beecham and Childress discuss other ethical frameworks that include virtue and relational approaches, in our experience, the 4 principles of respect for autonomy, beneficence, non-maleficence, and justice have often been favored in the practice of bioethics in the US. And by centering the 4 principles and marginalizing other ethical approaches and moral frameworks, we risk perpetuating the oppression of our patients and communities that aren't represented in the field of bioethics. For this case, it feels unjust that what is clearly the family's central the central value-based reasoning for this family isn't immediately and without advocacy fairly considered. And so in order to center equity and justice, we need to change our processes and elevate approaches that can center marginalized moral frameworks. Therefore, we propose an approach utilizing transformative justice that helps clinical ethicists meaningfully attend to diverse ethical approaches and analyze power imbalances. To transform the last diagram to better represent what we'd like to do, we converted this one here that doesn't appear to have a hierarchy or order of consideration associated with the pathways. And with that, I will go with Gina to go into this quote that resonates with both of us very strongly.
Thanks so much, Holly. So just as Holly said, we have felt like we needed a kind of framework to recognize and counteract oppression in the ethics consultation process specifically. And one piece of this is in the ethical reasoning itself. In other words, we really are hoping to work towards transforming our ethics practices so as to counteract or avoid a particular reality for some patients and communities that, as Foster puts it here, as soon as the patient is admitted to the hospital, she is subject to an entirely different philosophical jurisdiction from the one to which she was subject outside the hospital door. Now, this is just a start, but alongside our co-authors and many of our colleagues inside and outside of our institutions, we've begun to expand the standard frameworks that typically get employed in clinical ethics practices. And our goal here is not to abandon the 4 principles, though some might reasonably argue for that, but rather what we're trying to do is find a similarly practical tool or framework that draws standardly marginalized ethical perspectives to the center. We've organized this tool by approaches that we've seen to be relevant across stakeholders dealing or grappling with ethical conflicts in clinical settings, then offered key questions and tips for consideration. It's important to note that it's not meant to be a new list or an exhaustive list. These are very common ethical approaches that have been relied upon across societies and centuries. To some extent or another, many of these approaches are also present in Beecham and Childress's principles of biomedical ethics, though not always employed in clinical practice, as Holly mentioned earlier. The transformation occurs through expansion, inclusion, and recognition of power and privilege throughout this worksheet or this tool. And so if we take, for instance, thinking about the case you've just heard about, consider the consequences. Consequentialism, as many of you know, considers benefits and harms in a broad sense, typically. In the clinical setting, we often focus on how different interventions will affect the particular patient. In this case, though, centering the patient's well-being can simultaneously marginalize or obscure the consequences to the family or the patient as part of that family unit. So our tool demands that we ask how power and privilege affect what counts as relevant, as ethically salient consequences, and how those consequences are weighed against one another. So for Vivian and her family, we would want to be able to centralize the possible consequences to familial relationships with each possible pathway, integrate the moral priority or importance of family well-being in decision-making, and recognize how this family might be othered or marginalized for not using the same ethics language or prioritizing the same principles as we typically do in US medical culture, such as a priority or primacy of respect for autonomy. Ultimately, we want to be able to hold all these approaches together, such that one doesn't automatically outweigh the other simply because it's the more dominant value in US medical culture. So instead of one value or principle, such as respect for autonomy, automatically trumping another, such as familial well-being or familial autonomy, features of the context will help us to weigh and consider the different values and ethical approaches equitably. And with that, I will thank everybody again and turn it over so we can have further conversation.
Thank you so much. That was wonderful. I so appreciate it. And anytime anyone starts with Audre Lorde, you've got me hooked instantly. So that was a great talk. So just a reminder to everyone to please put questions in the Q&A. We're sort of saving all of our discussion for the end, but as questions come up, please put them in the Q&A so we can get to them. And I will introduce our next speaker. We'll turn it over next to Dr. Gail Henderson. Dr. Henderson is a professor of social medicine in the School of Medicine at the University of North Carolina at Chapel Hill. A medical sociologist with training in public health, her research is focused on ethics issues in clinical trial decision-making, race, ethnicity, and genomic research, and preventative genomic screening. She was department chair from 2009 to 2015, director of the UNC Center for Genomics and Society from 2007 to 2019, and member of the National Human Genome Research Institute Advisory Council from 2016 to 2019. Her most recent publication with Nancy King and Larry Churchill is Bioethics Re-Envisioned, A Path Towards Health Justice. So please join me in welcoming Dr. Henderson.
Jen, thank you so much. And thank you to Larry and Elizabeth for this opportunity to join in and talk for briefly about sort of the other side of the coin, which is sort of much more macro level issues and justice. And I really appreciated Holly and Gina's talk, and I'll refer to it a couple of times. So I'll just share my slides. Okay. So how I've titled this talk "Looking Upstream for Justice," as you know, I'm a social scientist working with bioethicists in an interdisciplinary department at University of North Carolina. So I bring a somewhat different lens to this, but my long time working with colleagues, I think in this recent book that we've published, I hope gives me some perspective on making recommendations. So all of you know that we have major justice movements in the United States, which are pushing a new vision, protesting social injustices, pushing for a new vision of equity. This is hardly bears emphasizing. It's been in our media, it's been in our literature, on DEI webinars. It's really everywhere. So, before we started, I asked Jen, well, what could we add? What in this webinar could we possibly add to the really amazing effort that has gone into considering racism, sexism, etc. And what I'd like to do is cover briefly what we have recommended, and this is Nancy King and Larry Churchill and I recommended in this new book of how bioethics might fit into this broad landscape. And we argue that bioethics needs an expanded moral vision. The field must embrace a broader and more meaningful view of justice, principally by incorporating the tools and the insights of social sciences, epidemiology, and public health, and work together to understand the ethical implications. We began this work, which culminated in this publication in 2020, and are painfully aware of the many articles that have and studies that emerged since then, but still feel that the thesis of our book is worth reiterating, and that is that the work of the bioethics field has been largely captured by the concerns of healthcare institutions, focusing on dilemmas raised in doctor-patient and investigator-participant relationships, by newly emerging technologies, informed consent, and other slice of time problems of lifeboat ethics, while paying less attention to upstream structural injustices and their profound consequences for the health and well-being of individuals and communities. Sorry, I have a cold. And we're acutely aware of the fact that many bioethicists have focused on justice, but we argue that justice, autonomy, and beneficence and non-maleficence are essential aspects of bioethicists' toolkit. Justice should be also. So, how do we interrogate justice and health justice? Gina and Holly's work features contextualizing interactions within the hospital, where many clinical ethics dilemmas, take place, and listening to narratives told by patients and families, offering a new ethical framework. And we support this approach wholeheartedly. But we also turn to health justice upstream, outside the hospital, considering structural injustices that create disparities and ideas about ameliorating injustices through community engagement. And I'm going to now turn to just a few sort of what I think are kind of take-home messages or important issues in epidemiology that are fraught with ethical implications. And the first is looking historically at the three eras in epidemiology. And here, the recent so-called discovery of structural and social determinants of health, it's really far from new. Over 150 years ago, without understanding the mechanisms of disease, medical and political activists like Rudolf Virchow and Frederick Engels identified poverty as the essential predictor of morbidity and mortality. But this knowledge was eclipsed by the germ theory of disease, identifying one cause and one outcome to which prevention and treatment strategies could be applied. So that was happy news for people who just didn't buy the miasma theory of disease causation. And it was a powerful theory of disease causality. And then since that time, even into the all parts of the 20th century and beyond, advances in statistics and epidemiology made it possible to measure many individual and community level factors, often identifying risk factors for a condition without the biomedical mechanism being understood. It's this so-called black box epidemiology. And for that, you just have to think of the famous study of smoking and lung cancer, which identified smoking as a risk factor, a powerful risk factor, but without really understanding the mechanism. So what happened during this time period as much more sophisticated models of disease causality were invented, there occurred something that has been called the epidemiology wars. Social epidemiology focused on societal determinants of health. Risk factor epidemiology focused on behaviors and exposures. Molecular epidemiology focused on biological mechanisms. But these are not value neutral. If one focuses on the proximate or very nearby factors that lead to disease, one tends to blame those afflicted. While focusing on distal factors, shifts to social structural conditions. And I was interested at Holly and Gina's use of the term power, and because Nancy Krieger reminds us that power is implicated in unequal systems, structuring exposures. So in the context of much broader kinds of studies of risk factors, we can't just assume it's value neutral. And I want to mention one of my hero epidemiologists, Jeffrey Rose, who wrote about how upstream population level factors should be considered, following social theorist Emil Durkheim from the prior century, who observed, okay, I may have to skip a little of this. But he observed that society wasn't just comprised of individual actors, but society was an entity in itself. And Rose, in sick individuals in sick populations, explored how characteristics of populations in which individuals live can be really different from characteristics of those individuals, that you can't take social facts and translate them to individual level factors. They're not the same necessarily. And you just have to think about what does living in a high unemployment area mean for individuals who are employed or not employed? It's quite different. Those without jobs are exposed, those with jobs are unexposed, but at a societal level, living in a high unemployment area has adverse effects on both groups. And I'm talking about these to give you a sense of the complications and the nuances that began to be articulated, not just this model that you can see on the right, where you have a lot of different factors, multi-level, macro, meso, individual level factors that are affecting individual and population health, but it began to be understood that it was so much more complicated than that. Hey, just a couple more, actually just one more data slide, and that is this, which is one of my other favorite concepts, and that is fundamental causes. Now, initially, Bruce Link and Joe Phelan argued back in the late 1980s and 90s that socioeconomic status is a fundamental cause. What does that mean? It means that their impact persists over time, despite really radical changes in diseases, risks, and interventions that happen to produce them at any given time. So individuals can have negative health outcomes just based upon their socioeconomic status and not related to these intervening factors. And unlike socioeconomic status, race in the United States has an enduring connection to health and mortality as well. And Williams, Lincoln Phelan, and many others have identified racism as a fundamental cause of disease. So in other words, in the same way, racism that is experienced by individuals, no matter what the intervening variables are, is a cause of poor health. And I also, I want to note that these initially were individual level factors, but lately, and most of you are very well aware of this, that research has coined the term structural to identify institutional and societal level factors that are similarly fundamental to analyzing disparities. And I've listed a couple of authors there, but importantly, and I think Jen, in her work on intersectionality, doesn't need to be reminded of this, but importantly, around this same time, Kimberly Crenshaw, a lawyer who was developing a court case for African-American women, realized that it wasn't just their being African-American or that they were women that produced discrimination, but it was the intersection of both. And just as with the fundamental causes, this intersectionality now, people have started to think about structural intersectionality. So looked at the level of, for example, states, trying to understand how structural intersectionality might affect health. So with that, I just leave you with these kinds of questions. Like, if you interrogate empirical results in disparities research, what would be the ways that collaborating with people like me, with social epidemiologists and others, what are the kinds of questions that should be asked of collaborations? Well, what justice implications are inherent in the empirical approach presented? And those were the examples, very brief examples I provided. And how are individual and societal level variables presented? How is the structure of society identified and analyzed as a fundamental cause of disparities? And are different dimensions of racism being measured, including structural racism? All of these have an impact on validity, usefulness, and possible intervention programs. And our goal, Nancy and Larry and I, in putting together the book, is to make an argument for collaboration between bioethics and social epi and other social science and public health fields, because it's important to sort these ethical implications together. So thank you very much. So sorry for my cough. I tried. Okay.
It was barely noticeable. Don't worry at all. Thank you so much, Dr. Henderson, for that great presentation and overview. Gosh, I think you raised such important questions, and I wanted to sort of continue to invite people to put questions in the Q&A, but also if folks have answers or insights or additional questions from those questions, I think those are great things to raise too for our discussion. So before we get into the Q&A, into the discussion, I get to take the prerogative to raise some of my additional questions first. So I'll just reflect for a few minutes on these two presentations and the two papers that upon which they were based. So, you know, I'm just really grateful to be in this conversation with these amazing researchers and ethicists and speakers today. And I know I'm not alone in reflecting on some of what Dr. Henderson spoke about on that 35 months ago now, which seems wild. You know, my life and work changed in really profound ways for all of us, right? The COVID-19 pandemic and the racial justice movement drew much needed attention on racial violence in this country in 2020, and it rocked many of us to our cores. There was immense pain and trauma across many communities, trauma that is continuing constantly, as we are seeing in the media. And what I think has been so profound for me is the way that health, medicine, and bioethics began for the first time, or the first time in a long time, to really, it felt like, take seriously social oppression. As a medical sociologist who's been studying and thinking about racism and intersectionality for many years, it's been a bit of the feeling of like, welcome to the party. It's kind of awful here, but there's some really excellent books I can recommend to try to understand it better. And as someone in bioethics, I felt really strongly that we must take this moment and make sure we're working towards doing bioethics differently, right? We're thinking today about bioethics with a bigger impact. And what's fantastic about these two papers is I think they're allowing us to think about bioethics and bioethicists and how they operate on many levels, sort of thinking on the micro, meso, and macro level. I think it's important to think about how we intervene to do bioethics with a bigger impact, but perhaps more importantly, how we make sure that as a field, we're mitigating harm that we as bioethicists can do and have done. So Drs. Campelia and Vo began their piece by asserting that clinical ethics consultants bear witness to the harm of intersecting axes of oppression. And I challenge this just a little bit slightly. I think ethicists witness harms of oppression every day, but I think the field has not done nearly enough to bear witness, that is to make testimony of these harms. And we certainly have not led the charge of speaking out against them. The authors argue that the four principles have failed to address oppression, and they assert that while they have been adapted in the US, the four principles have been adapted in the US for their depth, complexity, and applicability, they also align with, quote, Eurocentric priorities of impartiality, universality, and liberal individualism. And I think this speaks to a few, but I'll point to one sort of central problem in the field. Bioethics still has a problem of privileging impartiality. And this is both concerning in the case of questioning the role of those with lived experience being leading voices within the field, discussions that remain ongoing. There was a recent AJOB issue that wrestled with this. And it means that bioethics, I think, still often shies away from the political. The truth of race as a social construction that Dr. Henderson spoke to, and racism as a fundamental driver of health disparities, is not new. It's been well established in the social science literature since the late 1900s. And I love saying it that way because it makes it sound even more old-timey, like the late 1900s. But yet, until 2020, discussions of racism, I think, were still quite marginalized in health, in medicine, and in bioethics. An understanding of racism and intersectional oppression and their links to health outcomes, I think many of the things that were cited here today are great ways to learn about that, should be absolutely mandatory within our field. I think to study or intervene on health without this knowledge should be considered tantamount to some sort of bioethical malpractice, if such a thing exists. The conversations we need to be having are the ones raised in these discussions, not are these things real or do they need to be considered within bioethics, but how do we operationalize them? Over the last few years, we've seen many calls for, yes, please, let's talk about racism as important. How do we move beyond that to think about how we operationalize these concepts and actually intervene? Dr. Henderson raised the question in her piece of if DEI trainings will lead to meaningful change. And I think this is a really important question and one that shows my deep cynicism, because I kind of think, no, DEI has never been about structural and institutional change. Racism is embedded in our system so deeply, we need to find new tools and bigger ways to address it. And I think Drs. Campelia and Vo offer a new model for doing this through transformative justice. How do we think about transforming our systems and our tools in the pursuit of justice? This is a way to operationalize this work on the micro level in the context of clinical ethics and the patient-provider relationship. And I think there's an important reminder that ethics can't stop at the clinic's doors, right? We can't just be content to bear witness to think through the harms of intersectional oppression we see in the clinic. And Dr. Henderson reminds us to look at the social determinants of health. I argue that racism is a structural determinant of health, right? We can't ever fully address all the social determinants of health, like housing, food, education, transportation, access to healthcare, and on, if we don't intervene to address racism. And this makes racism a key bioethics issue. We have a collective moral responsibility to intervene on structural and societal levels. We must consider how to have not just a bioethics, but perhaps a biopolitics that centers within our discipline the need to intervene on systems of power. Dr. Henderson just mentioned lifeboat ethics. I think this is such an apt metaphor. I think we both need to see if we can stop the stream or build a dam or some other metaphorical things we do with water somewhere. But I also think we need to think about if and how there are places where bioethics is adding more water, either to the lifeboat itself or to the river that it's rushing down. So I want to zoom back out or back in for a second. So from the macro to sort of really think about the meso. I think we have to remember that healthcare isn't only the site of the downstream effects of racism, but a site of the perpetuation of harm itself, right? It's a place where racism is created, it's reified, it's perpetuated every day. those of us who work within hospitals and academic medical centers must ask ourselves, how are we addressing the racist harms perpetuated by our institutions? And so I'll offer a few examples to think through. On which families is Child Protective Services called at your institution? Which departments have security or police stationed, and who are the people who are seeking care there? My cat's here. She has a really strong feelings about racism in medicine. When a patient comes in shackled, is it the policy of the institution to have the shackles removed? What type of language is used in medical records to indicate when someone is choosing not to follow the advice of their provider? And is that different across different types of patients based on how or why they're declining care? What are patients' experiences at birth, and what are the birth outcomes at your institutions? Do residents of color feel supported by the institution? What about the non-clinical staff? How do they feel within this environment? And I think, sort of what I think about is healthcare should be a fundamental right in this country. I assume many of us think that. It's not, it should be. But what's really concerning, and a point where we can really intervene, is the way that health and healthcare end up being the site of violence, oppression, and harm for many. So what's the role of bioethics? Are we seeking to protect the systems and institutions that perpetuate harm, or to transform them to better serve our patients? Are we seeking to uphold power or center and engage community instead as a way of decentering that power? So my question sort of to all of you, everyone here, is how can bioethics be a leading voice in this conversation? What is our impact on these systems of oppression? Are we perpetuating them, or are we able to intervene? So those are all really big and slightly rhetorical questions. So to segue to our Q&A, I'll invite our panelists to join back on screen and ask something more concretely, maybe slightly, maybe, I don't know, maybe it's not concretely, but I think of it a little bit anyway. So in thinking about social oppression, how do you think bioethics falls along the spectrum of intervening or causing harm? And what are the ways that we can or should intervene on the harms and oppressions caused by our healthcare institutions? So if anybody wants to jump in.
I just want to thank you so much, Jen. I thought, just as Gail said in the chat, that your comments are so just acutely on point and really resonate with me and the work that we've been doing as ethics consultants with many of our colleagues at our institutions. I think that thinking about interventions at all of those levels is critical. And while in some ways what we were talking about today is on a micro level, it intersects with that meso level in many ways, right? Thinking about the makeup of your ethics committee, who representation among the ethics consultants, and our practices, our processes, right? So part of the work developing this tool is to say, look, we're relying on Eurocentric, Euro-Christian values in US medicine that don't always resonate and actually marginalize in other value systems within this country. And so finding ways to dismantle the aspects of white supremacy that come through that, right? So the impartiality you talk about, the thinking that there's an objectivity here as opposed to subjectivity that's imposed to ourselves as ethics consultants in some ways. And so I think that's something that Holly and I and our co-authors and other colleagues at our institutions have been working on, knowing, and I think a lot of ethics consultants struggle with knowing this is the case and then also not having alternative framework or practices to rely on. And so that's the work we're doing is we're trying, right, this first step down that road, right? So many people have talked about these issues, and even though that discussion is often marginalized in mainstream bioethics, there's been plenty of work on that point. It's there at our fingertips. The question now is, how do we integrate it, not just in how we interact with specific patients and colleagues, but also in our general practices that are guiding our committees and our consultation processes? How do we advocate for changes, such as having not just an ethics consultation service, but an equity consultation service that can operate together in unison And so, so those are some of the things we've been thinking about.
And I'll say, to add on to what Gina is saying, which is very much what I was thinking as well, is that we really work on, within our ethics consult services, we have all these frameworks that we have learned and we've kind of dabbled in, but there's like main dominant ones that we work with, which is from our experience, is like the 4 principles. And I think that one of the goals for setting up this new approach is to also allow different questions that ethicists can ask themselves and relate it to each particular patient. So that's more of a systematic way of approaching it. It's not that like, I know all these frameworks, I get to the bedside, yet I kind of like default to what has been practiced or what I know is more commonly practiced, but then using a systematic questioning approach to ask for each actual intervention, or I'm sorry, each actual in consultation, can help bring in the issues of racism and white supremacy and anti-Blackness in a way that perhaps may be overlooked or not as present and easy to integrate into our current systems.
That's super interesting. And just as a follow-up to that, I think there was a question raised in the Q&A about, are there other countries or other models we should be looking to for guidance on ethical practices that aren't so centered on autonomy, that aren't so centered, you know, the ways that are sort of, as you mentioned, like our Eurocentric approach to care? Who do you sort of look for as examples, or should we be looking for towards as examples?
It's an interesting question because those value systems are in the US too, right? And so it's not like we have to look internationally to find value systems that are grounded in worldviews that are marginalized in the US and even originate on the land and territory that we now occupy. And so that, I think, it's a really important question, right? Who do we look to? Ideally, a lot, right? A diversity of value systems. The key, I think, that we tried to draw into the tool is the analysis of power. So which value systems are marginalized, othered, oppressed, in some ways, regardless of where they're coming from or originating or what worldviews they rely on or what value systems, right? But to some extent, really acknowledging the dominant value systems originate in a Euro-Christian, Eurocentric model, worldview even, and that's not the only worldview that lives and breathes in the US. And so I think that is part of the work that we're trying to do is that combination of recognizing, looking around us, they're here, right? That it's not like we have to go outside the US to find a diversity of worldviews and value systems that arise from those.
So, and I just wanted to say a couple of things in response to your really excellent discussion. One is that social epidemiology also, and other kinds of social science disciplines, always have problems with impartiality. And those who step out of those bounds, like Nancy Krieger at Harvard, are had not necessarily been the norm. Although the work that, I mean, it's very hard not to want to cite her work because she does talk about the ways that power and privilege structure exposures. And those can be translated into what now people are talking about with structural racism, structural social conditions, or structural social institutions that are structuring according to not just race, but class and other aspects of marginalizing people. So that's something that I think it's a kind of false idea that the methods, that epidemiology itself is going to give us sort of the truth. And in fact, no, not hardly. But what it does, I think, increasingly is give us tools to problematize and really attend to the ways that measurement may be structuring the kinds of answers we're getting, the biases that are inherent in almost everything we do. And I think that kind of empirical approach is bereft without an ethical or bioethical sort of partnership that to which we can say, well, what are these things that we've learned data-wise, and especially what's missing? Because a lot was missing until recently. And that makes me want to ask, sort of back to you, Jen, and to the others, that the last 3 years and the ways that racism has been not only uplifted as a theme, as a social movement to counter it, et cetera, but also as people who are really trying to understand how to measure this and how to demonstrate empirically how toxic it is for health and for other kinds of outcomes. So it feels to me like, and I guess I'm also coming off watching the 1619 Project on Netflix. I have to just raise that because I'm so profoundly impacted. Coming from UNC, you can understand my sense of loss there. That we've got a really different articulation of our history, of what's happening both on a micro level as Hannah Jones talks about her own family, and on macro level as she talks about the history and some of the horrific events that with slavery and the aftermath of slavery. So I feel we're in a different world now, and I would like to think that we're in a world where we can just leap forward and make big progress on addressing what now we have data and we have concepts and frameworks, as Gina and Holly have put forward, to really reconsider what it is that we're doing and understanding. So I'm sure I had other things to say, but I forgot.
No, that's great. And, it links to something that I've been thinking about, and also a question that came through that I want to ask. Yeah, I think you're right. I think we've moved this conversation forward. I think many more people are comfortable sort of with both addressing our own sort of like implicit bias, acknowledging, and as well as that like racism is a thing in our society. I think there's a lot of acceptance of that within our field, like sort of that truth. But I'm still struggling with, are we at a point where we feel like we can do things about that? Do we have the tools necessary? Do people feel like they have the ability to do it? And a question in the chat was, feeling like, how do we push for social and political change when the systems we work for might be hostile to that? Like, our hospitals don't necessarily want socialized medicine and they pay our salary. I'm thinking about colleagues working in Florida where I'm hearing like, they're like requesting everyone's emails to see if they're mentioning DEI and CRT. Like, we live in a society that is very hostile to this. And, I see it, how am I advocating for like changing systems that benefit me, right? Like the way that like NIH has funded research has been quite racist over the years. Am I intervening on that, or like riding the wave to my own NIH grants, right? Taking advantage. So I'm curious how you all think about both do bioethicists have any sort of special moral imperative to act that's beyond what an epidemiologist might have or any other field? And yeah, how do we work within systems that might be hostile to that kind of change, knowing that like there's a lot of them out there? How do you all think about approaching this work? Assuming any of you are like, well, this is how I overthrew my hospital system, let me tell you about it. But no, I mean, it's all.
I just wanted to quote Lisa Parker, who argued that bioethics can and should be a form of activism, going beyond the focus on the individual to taking up issues better analyzed through the lens of population-based approaches, group identities, and socially constructed vulnerabilities. So, and the first part was what I wanted to ask you all about. That, because I think you're right. I think people who take up activist stances within institutions don't always fare well. But that's what she thinks for bioethics is should be.
In my limited experience, I don't have the answer to your question, Jen or Gail. Like, those are very big and wonderful things for us to be thinking about. But I think from what I've read and what I've learned, what I find in the field of bioethics is that we are slower than other groups and other communities in our country to try to take a better and stronger activist voice. And so I think for me, it's a lot about learning from collaborators. It's a lot about learning from groups who've been doing equity work, CRT, groups who've been doing advocacy, and finding ways that we can join and elevate voices that we know and recognize, like you said, it's our moral imperative. Like, we know that this is wrong, but we haven't been great in the past many decades of actually doing something about it. And so I think that from the work that Gina and I have been working on, we take a lot from CRT colleagues. We take a lot from theories of other people that have written about how to do this and trying to incorporate into a more systematic way of doing that. And so my small answer to your big question is, I think we really need to start outside of bioethics and learn from others and do this better. I think we need to, and we can eventually when we learned how to.
I think I agree, Holly. And I think another piece of this is sometimes we put a little bit too much under the activism umbrella when really it's just good healthcare practice or good ethics, or right. So thinking about, so as an example, right, it can, there's a lot of back and forth about whether and how to talk about racism in a chart note. And so I think that as an example of how do I incorporate that into my ethics note, and what's the best way to do that, and when should I do that, and so on, knowing that that's not an activist move, that's just part of acknowledging ethically salient, clinically salient features of the context of that patient. And so I think balancing both what is our role to really push change in the activist sense, whereas what's just our very basic role to push change because what we're doing is harming people in very real ways, and it's not actually effectively supporting health and well-being. And I think a lot of what Holly and I and our colleagues have been working on in our papers is actually that first part, right? Some people might categorize it as activism, but I don't think it is. I think it's really just trying to make sure that our ethics practices are just and right, and leading to, supporting and facilitating good patient care, or counteracting ways that don't. So I think that piece too is, in addition to what people have already said, is something I think about as well.
We're somehow already past the point where I was supposed to wrap us up and say the last question. So instead of doing that, I just wanted to sort of actually pull out some things that folks raised in the question and just sort of throw them out there, because I think a lot of these are questions that none of us have the answer to, but we all need to think about, and some of them are ideas. And so I just wanted to just go through a few of those and then turn it back over to Elizabeth to wrap us up. But first, just highlighting whose voices are in ethics consultation. So people are asking, what do we do how do we think about the white supremacy that's embedded in our ethics committee and consultations? I think that's so important. People are asking about how we advocate and think about narrative ethics and narrative medicine, and the role of other professionals like chaplains and like social workers to intervene on multiple levels of these systems. So I think thinking about who all is in the room for these conversations and how we expand that is important. People are asking what data we should be collecting to see how our institutions are doing. I think that is a phenomenal question that we should all be asking at our institutions. What do we already know, and what can we know? And people are talking about something that I think is such an important point to end on, is how we engage community. How are we inviting community into these decisions? How are we thinking about and privileging community, which I think gets to some of the topics of relational autonomy that came up. And how do we make sure that we have broader representation in these decisions? So I think I just sort of want to end my thoughts with, I think there's a big conversations about what knowledge is privileged, what ways of doing this work is privileged, and how do we keep expanding that to thinking about the people who have been doing this and doing this well across many disciplines for many years. And so that's where I'll stop. I'll turn it back to you, Elizabeth.
Gosh, thank you all so much. I think that as Jen just said, the many really extraordinary, deep, thoughtful questions that the audience is bringing up, I think demonstrates the necessariness of these conversations in order for bioethics to have a bigger impact, and trying to shape what that impact will be. So I want to extend a huge thank you to Drs. Campelia, Vo, Henderson for their essays and the Perspectives in Biology and Medicine Symposium and their presentations today, and to Dr. James for sharing your expertise and moderating our time together, which has been just fabulous. Larry Churchill and I are so grateful to Perspectives in Biology and Medicine for hosting the symposium on the translational work in bioethics, and for Johns Hopkins University Press, who has currently made the entire issue freely accessible. So please go out and check out all of the essays. There's no paywall. Share with all of your academic and non-academic friends and colleagues. It will be accessible all month. And thank you so much to the Hastings Center for partnering with us to bring this Bioethics with Bigger Impact series to life online, and to all of our sponsoring institutions who are getting the word out. So the Institute for Philosophy and Public Policy, the Vanderbilt Center for Biomedical Ethics and Society, the Harvard Center for Bioethics, and the Center for Public Engagement with Science at the University of Cincinnati, on whose YouTube page you will also be able to find a recording of this session, or you may be watching it there by the time you see this, right? So today was the second part of a 3-part series. Stay tuned for more information about the final session on climate change and environmental ethics and bioethics that's going to come up this spring. We very much hope to see you there, and thank you again for joining us today.
Thank you.
Thank you all for attending. As mentioned, a recording of this webinar will be available later today on the Hastings Center website.